Can you unshare Taimur for a second?
Can I what?
Unshare the screen so that
Unshare.
everyone can.
Unshare. Okay, yeah, sure.
Yes. Hello, everyone. Thank you so much for joining. Let's give it a couple more seconds for people to join. Thank you, everyone, for joining us in today's webinar about Lenacapavir. I am really excited to have the discussion that is going to be discussing the innovation of Lenacapavir as this new kind of technology for prevention, the impact in our communities, but also discussing not only the science behind it, but also what can we as advocates do to ensure that there is access for this new technology. Today, I am joined by Taimur Khan from Fenway Health. And I am also joined by John Rowell and Jason Watler, who are fellows of the Gay Men of Color Fellowship, and also Taimur that served as a mentor in the previous cohorts. For those that don't know, the Gay Men of Color Fellowship, what we are trying to do is to engage in conversations like this, inform the community about topics that are relevant for advocacy, for people to really have the tools to engage in meaningful conversations and take decisions about their health, informed policy, but also to form advocates that are informed to take actions that really have meaningful engagement in taking decisions at the state level, at the national level, in policy. Before we start, I'm going to welcome Taimur, John, and Jason. If you can introduce yourself. Taimur, would you like to start?
Yeah, happy to. Hi, my name is Taimur Khan. I use he, series pronouns. I'm the Associate Medical Research Director at the Fenway Institute and in Fenway Health in Boston. I'm grateful to be here. And thank you, Damien, for asking me to speak.
Yeah, happy to have you here. John?
Howdy, hi, and hello, everyone. I am John Rowell Jr. I'm from Fayetteville, North Carolina, currently serving as the Associate Director of Prevention with the Alliance of AIDS Services Carolina out in Raleigh. And I am happy and thankful to be here.
Great to have you here too. Jason?
Hi, everybody. My name is Jason Watler. I am based out of Washington, D.C. I work for Us Helping Us People into Living as a patient navigator for the Hep C Free Corridor grant. And I'm really happy and excited to be here.
Awesome. Thank you for being here, for taking your time to joining us in this conversation. Um, Before we start, a brief agenda for today. We're going to have a presentation with Taimur about kind of the science behind Len, and we are going to be engaging in a conversation with John and Jason, and also with the audience in terms of access and things that advocates should know. And before we start, this is a shameless plug. NMAC is part of the Let's Stop HIV Together campaign with the CDC, where you can find resources, social media posts that have amazing visuals. They even have the captions that you can use in your own social media to engage your communities. And I'm going to be posting links on the chat to access those. And also, if you or someone that you know needs an HIV test sent to your home, you can access those. You can order those from the Together campaign. And I'm going to be posting those on the chat. And now, without further ado, I am going to pass it over to Taimur. Thank you for being here, and Taimur, take it away.
Hopefully you can't hear that. There's a door that the alarm is going off right outside my office, but I'm assuming we're okay. So
We cannot hear,
great,
so it's fine.
amazing. All right, my goal is to not get distracted. All right, Damien, can you tell me if this is the right view?
Yes. Yeah, just
Perfect.
the
All
slide.
right.
Perfect.
Awesome. So if folks have questions, feel free to put them in the chat. We'll try to keep an eye out on them. I think we're going to try to save time at the end, obviously, to have that conversation, answer questions. But if there's a point of clarification, please feel free to put it in the chat. As I mentioned, Taimur Khan, he series pronouns. I'm a physician. I'm also an infectious disease specialist. I do community level trainings for providers and support staff, as well as some educational series here through the Fenway Institute. And I'm really excited to be here to talk about Len. Let's see. And just so some background on where I am and what Fenway is. If you don't know, Fenway is located in Boston. It is a federally qualified FQHC. And within it, we've got a research policy and education department that's embedded. We see approximately 36,000 patients a year with over almost close to 3,000 now, people living with HIV. And then we've got several thousand that are on PrEP, different types of PrEP. And the Fenway Institute was heavily involved in some of the early PrEP studies, which I'm going to get into. And so I do have some disclaimers. I serve as the sub-principal investigator for Purpose 2 and Purpose 3, also known as the HBTN 102 study, which was looking at evaluating lenacapavir for HIV prevention. I'm also the principal investigator for Purpose 365, which I'll refer to a little bit later, just so you're aware. Just want you to know that my views expressed in this talk are not necessarily those of the study sponsors, affiliated institutions, but just from my experience and from what the data shows. Again, it's important that I disclose that. I've already started talking jargon, I've already started talking science, but I think it's really important. I try to do this with a lot of my talks to just center us in the lived experience of the people that receive this medication or any preventive medication, and talk about what sexual health is. I really like this definition. It's from the WHO. It's on their website. It's still there. I checked today. But it states that sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of a disease such as HIV or dysfunction or weakness, but that sexual health requires a positive, respectful approach to sexuality, sexual relationships, as well as the possibility of having pleasurable, safe sexual experiences free of coercion, discrimination, violence. I think it's important. We think about risk a lot in terms of when we talk about HIV prevention and treatment. So I think it's important that we center pleasure, safety, consent, and choice. So that's just getting us grounded, because I'm about to jump into a lot of science, and we're going to maybe lose that human touch for a second. So ending the HIV epidemic, it comprises of a few different approaches, right? So one is to understand what an individual status is. So diagnosing folks with or without HIV, and then treating people that are living with HIV to get them virally suppressed. So that way we can also empower them to live healthy, complete lives. And also, as we know, U equals U, and treatment as prevention is extremely effective, 100% effective in preventing the spread of the virus. And then obviously there's this preventive part of things, which is what we're going to spend most of our time talking about. So as you've heard, lenacapavir, Len, what is it? So lenacapavir, it's what's considered a small molecule capsid inhibitor. This is the first of its kind. So in the advent of HIV treatment and prevention, there's so many different mechanisms and drugs interact with certain parts of the cell and the life cycle of HIV. This one is novel. It is brand new. And so lenacapavir, and I'm going to call it Len for short, was actually approved for treatment for HIV in people that were really treatment experienced. So people that have had prior regimens, have some resistance. And that drug name, just so y'all are aware, is called Sunlica. And it was approved in 2022. So kind of recently. And it was also an injection subcutaneously every 6 months. So that's what we know previous to Len being approved for PrEP, or pre-exposure prophylaxis. But this image is helpful because it shows that it doesn't just act in one space, it acts in a few different spaces when we're thinking about the life cycle of the virus getting into the cell. So that makes it really, really powerful in terms of its ability to act effectively. All right, let's rewind a little bit. How did we get here? So a lot of HIV PrEP work, and this is going to be just about PrEP now, the slide. IPREX was our first study looking at generic Truvada or tenofovir emtricitabine, and then there were the partner studies, which looked at U equals U, and then there was a Bangkok TDF study, and then we had IPERGAY, which was looking at on-demand PrEP. But FDA approved our first oral PrEP in 2012. Then we had the approval of our second oral PrEP tablet, which was a slightly modified version of the first one, which was then approved in 2019, so a little bit of a gap. And then in 2020, right, literally as COVID was peaking, a lot of centers had to deal with some of the financial consequences of Truvada going generic. And that was in October 2020. Shortly after that, we had the FDA approved injectable cabotegravir, and that's from our HPTN 083 and 084 studies, which were through the NIH. And that brings us to now. So Purpose 1 and Purpose 2 were the two studies where they shared data, disseminated the data in June of 24, September 24. And then shortly after that, in June of 25, the FDA approved Lenacapavir for PrEP under the name Yeztugo. Additionally, that's not all, right? So on the right side, you'll see here U equals U is really effective in prevention. You've got syringe exchanges programs effective in prevention, PEP or non-exposure prophylaxis, pre-exposure prophylaxis. Non-occupational post-exposure prophylaxis, as well as daily PrEP or on-demand PrEP. And then there are a few other things that are in the works, and I just want to let you know that we're not stopping just because we've got these 4 drugs. There is a monthly oral PrEP tablet that's being studied right now. There are broadly neutralizing antibodies, which, when used in conjunction with lenacapavir subcutaneously, could provide adequate treatment for people living with HIV with only a few visits to the doctor. And then there are other modalities, including long-acting implants and long-acting vaginal rings. So this is stuff that's on the horizon or being worked on as we speak. But coming back to Len briefly, Len was then, after being approved in June 2025, in September, the CDC put out formal guidelines stating that lenacapavir, when administered subcutaneously every 6 months, is recommended for HIV pre-exposure prophylaxis for people with appropriate weight for PrEP. And it's a strong recommendation based on high certainty of evidence. So this is where we got a lot of our national guidance on how and when to provide lenacapavir for pre-exposure prophylaxis. Now, just so you know, I mentioned there's more going on, and I think in the earlier disclosure slide, even mentioned that I was part of a couple other studies. And just so y'all are aware, because it's going to be in the news sooner than later, the purpose studies done by Gilead were a bunch to look at Len for prevention. And so the one that I'm currently involved in is looking at Purpose 365, which is once a year intramuscular injection for pre-exposure prophylaxis, which is exciting. And so we're done enrolling in that. They're in the follow-up period of that. And then Gilead has realized, and so has the science community, and I think the NIH will be putting out some more calls for research soon, but looking at implementation science. Now, how do we go from having the science and how do we impact the community, which is our other speakers going to kind of touch on a little bit later. And there are a bunch of these implementation studies here, which is access with purpose, which I'm not going to get into. Suffice to say that I think the healthcare community and the science community is fully aware that just having the science is not enough. It's not enough. Real world experience, policy, systemic racism, institutionalized inequality are all things that factor into how people get these medications. And so it's important to look at those. All right, so let's do an assessment of where we're at. We are currently at having 4 PrEP modalities right now that are FDA approved. We've got the 2 oral PrEP modalities, which they can be used daily or on demand. And then we've got cabotegravir, which was approved a couple of years ago, and that is the one injection intramuscularly every 2 months after a loading period. And that's effective in all demographics. And then we've got lenacapavir, which is a subcutaneous injection every 6 months, and it's 2 injections in 1 visit. So those are our tools. Now you're probably asking yourself, well, how effective is lenacapavir? That's a great question. So when we look at lenacapavir, and there's some new data as of last week at CROI, which I'm going to touch on very briefly. But when they looked at the studies, of the 5,000 participants that have been involved, there have been only 5 breakthrough HIV infections observed. This was addended to the 2 previous seroconversions during the study trial, and they talked about that at CROI this last month. I'm going to get into it very little, but I think the important thing to stress here is among the 3,000 people that were getting oral PrEP, there were 77 seroconversions. So you can tell that when compared to oral PrEP, it is superior in terms of efficacy, right? It's not 100%, but it's very, very close. And so I stole some of the slides right from from Croy last month, which was in Denver, and they looked at Purpose 1 and Purpose 2, and they looked at the 5 seroconversions that were documented. And there were a couple where there was a missed study visit, but then there was one or two that they could not understand why the people had seroconverted, even when they were getting an on-time injection. So they're still figuring that out and trying to investigate it a little bit more closely. Regardless, 5 compared to 77, it's a no-brainer in terms of which one is more protective with lived experiences going on. Now, the few things I want us to think about now that we've talked about the science. So we've talked about the drugs, we've talked about where we came from, we've talked about why it's important. The one more thing I'll say is actually, I don't have a slide on this, but I think it's important. And they talked about this at Croy in 2025, last year, which was when we provide additional modalities for prevention, the uptake of all of them goes up. There have been similar studies looking at contraception that when you add another different modality of contraception on the market, not only do oral contraceptions go up, IUDs go up, implants go up, because there's more choice, there's more conversation, and there's more uptake across the board. Same holds with PrEP. So even though we may be thinking, we got a couple of really effective things, why stop there? It's important that we provide additional choice to folks. Okay. Having said that, let's move into lenacapavir considerations. So I think assessing appropriateness will depend on your healthcare center and where you get your care. At Fenway, I treat it kind of like, as I mentioned, contraception. If you don't want to get pregnant, here's contraception. If you don't want HIV, here are your choices. There are some centers and some community health clinics that are more particular about this. They will ask for recent receptive anal sex without a condom. They'll ask about recent bacterial STIs, etc. I don't necessarily fear that's necessary. I feel like that is a risk-informed management, whereas I would rather have the patient feel comfortable in having pleasurable sex where they're not thinking about the risk of HIV. And so I just provide HIV prevention whenever they ask for it. I don't ask too many questions. But the main thing you have to do for anyone that's naive to being on HIV PrEP is to assess a viral RNA and an antibody. You have to get both of them. If they're already on a PrEP regimen, you can just check one and move on. And then the next thing you have to do is you have to check for drug-to-drug interactions. And I don't want to belabor this next slide. It's really not that many drug-to-drug interactions, but the most important ones that we've noticed, and the nice thing about this is a lot of these, you just have to adjust the other drug. And for providers and clinicians, they'll know because the EHR or the pharmacist will alert them that this is something they have to consider. But a few things that are important here to consider is that for certain hormones, no adjustment necessary. Great for our gender affirming care and PrEP services that are provided at the same time. The ones that are worth noting are some of the erectile dysfunction medications. You may have to see a dose adjustment. Methadone, fentanyl, you may have to do a slight dose adjustment. But those are the big ones that I see. Rifampin, rarely see it, and some of our anticonvulsants really see it. So that's something to be aware of. What else should you be aware of? The way we provide lenacapavir to start it off is you receive an injection, and that same day, as you're getting the injection, I usually have patients do it right after they get the injection. You take 2 tablets of oral len. It's a loading dose to get your body up to a certain amount. And then the day after, we send them home with 2 tablets. And depending on where your center is and how they do it, we'll either do a phone call to the patient and be like, hey, did you take the 2 tablets? Or we'll do a video, or we'll have them come to the clinic, like a directly observed therapy. Depends, again, on your center and how they've implemented this new regimen. And then we don't see you again for 6 months, unless if you want to get an STI checkup in the middle, right? So not a lot of checkpoints, but it is important to note that there are a couple oral loading pills at the beginning. For people that take oral tablets on time, so on day 1, they take 2, on day 2, they take 2, we have found that in addition to the injection, that early data suggests you are protected from HIV 2 hours after your first injection, first 2 tablets. So that's good data. Now, if for some reason tablets go out the window and we don't have them for whatever reason, patient doesn't take them, they throw up when they get home, fill in the blank. They believe that early data suggests that you're protected at 20 days after the first injection. But, most patients have had no issues with the tablets. All right, so that is kind of like the way it practically works. Where do we get injected? So the difference between intramuscular, which is a deep reservoir in the muscle, which you might not notice, and a subcutaneous is this is a little bit closer to the surface, right? So in the studies, Purpose 1, 2, and 3, they were actually looking at abdominal injections. We have since been allowed to also do injections in the back of the arm under the subcutaneous tissue. Important things to note. Because we create what's called a depot, like a little reservoir of the drug, there is a nodule formation. It is not painful. I have not had patients say it hurt them, but they do notice nodules a lot. And they will stay there for a short amount of time. Now, if you're a very lean person, you may want to do the back of the arm if your abdomen is very lean. And some patients don't even notice it, but it is something that has been noted more in subcutaneous prep than intramuscular prep, I would say, at least in my personal experience. And the important thing here is that even though a lot of people experience what's called injection site reactions, predominantly nodules, the pain actually goes away pretty fast. No one stopped taking the medication. No point where someone like, this is so bad that I don't want to do this anymore. They still found it to be extremely beneficial, and it did not change a lot of folks' adherence to the medication, which is great. All right, so a lot of science. We talked about side effects. We talked about the injection, how you take it. We talked about protection levels. And here's just some additional data that if you're ever interested, you can hear about how there's been a call on the global level to kind of get the drug more readily available for more people. It's great that we've got this tool, but how do we get into the hands of the people that need it the most, right? And I'm just going to throw some data out there. There's no slide on this, so I'm just going to say it, which is that right now, the cost of this medication without any insurance coverage is approximately $28,000 per year, which is just slightly higher than if someone were taking what's called Descovy or the more branded oral tablet, which is about $26,000 a year. So a little bit difference, right? But what's important is also how states are putting this medication on formulary, Medicare, Medicaid, as well as state, private, and public insurance, and how those are being subsidized, and also how Gilead is paying for copay coupons that can kind of curtail some of the costs. And I'm excited that we've got a few other people here to kind of talk about what that looks like on a more practical, community-based level, because lived experience is what's going to dictate what happens next, right? I will say, and I don't think I have any more slides besides the questions thing. I'm going to turn my slides off and just talk. I will say it has been interesting to watch centers pivot to injectables at peak COVID times, right? There's already healthcare burnout occurring. There's folks that have left the healthcare system. There's new providers. People are complaining, my provider left, I have a new provider, et cetera, et cetera. And then on top of it, there's new ways to provide these preventive treatments. And it has not been seamless. It has been very ungraceful and clunky. And so I just want to name that even though these things are available, there's still a lot of centers that are not comfortable with providing injectables. Part of the reason is also because of the heterogeneity and how it gets approved, right? So if you go to a center, you come to Fenway, for example. You come to Fenway and we say, all right, we're going to put you on injectable prep. There are two options that occur at that point. There's something called buy and bill, which means that the healthcare center will buy the drug, and then once they give you the injection, they'll charge it to your insurance, right? So there's an upfront cost to the organization. And if your organization is kind of running fiscally very tenuously, they may be apprehensive about putting in the initial money. Then there's what's pharmacy benefit, which is you come to a place like Fenway where we've got a pharmacy, you pick up the medication from the pharmacy, it goes straight to your insurance, and then it comes to us and we do the injection. So suffice to say that there is a lot of difficulty in tracking how things get covered. Some places have done a really good job in terms of streamlining this with a navigator. Fenway has started that process. I think we've got like 60 people on LEN. That's not even including the folks we've got on CAB or oral. And so I think places that have gone through the initial growing pain are coming out on the other side of it now, but that is not true for a lot of folks, a lot of organizations. So I'll name that. I think there's still the fact that there's still continued research on this, and the fact that Purpose 365 is somewhere on the horizon, or so are monoclonal antibodies, broadly neutralizing monoclonal antibodies. I think there's excitement that there's going to be other ways to prevent HIV. And I think the fact that the global community is encouraging creating a more generic version of lenacapavir is exciting. But we'll see what happens, right? It has to first get out there. The information has to get out there in forums like this. People have to talk about their lived experience. And then we'll go from there. The last thing I will say is that Len, as I mentioned, is not only for prevention, it's for treatment. You may see headlines coming out in the next couple of weeks that for treatment, there's an oral lenacapavir with bictegravir that has been shown to be really effective in people with really complex HIV treatment regimens. So again, not in the context of Len for prevention, but Len for treatment in an oral form has also been shown to have some benefits. So with that, I'm really curious to hear what John and Jason have to say in terms of how their experience has been with the medication.
Thank you so much, Taimur, for that comprehensive presentation. I really appreciate it. And now we're going to pass it over to engage with every one of us into a community conversation. Also for the audience, you may use the Q&A box for submitting questions, or just put them on the chat and we'll be happy to read them out loud and get your questions answered. I wanted to start the conversation by commenting because Taimur, you showed the kind of the timeline of innovation, basically, starting with oral PrEP in 2012. A lot of time has passed, right? But we still see disparities in terms of these new shiny technologies that they are indeed innovative, but we see many gaps in terms of access and who is accessing these technologies, or who has the information, or who is informed to even ask their doctors about Len or about PrEP in general. We still see many gaps in terms of information, or feeling comfortable to engage with these conversations with providers, or providers being informed about what PrEP is and what it entails. So I wanted to start off this conversation with Jason and John regarding access, right? What have you seen from the communities that you represent in terms of access, or in terms of what we can do to make sure that people know more about these new technologies, and how they can engage maybe in policy or in other areas to ensure access? Let's start from there.
Okay, I'll go first. So for access wise, so I live in Washington, D.C., so there's a lot of access for PrEP. I think the issue usually falls down to stigma. And a lot of times, especially when I am talking to people that I'm testing about PrEP, they may know about it or they may not know about it, but they may not see themselves on it because they still see they may have the misconception of PrEP being a medication or a drug for gay men. So again, we go back to the whole stigma of HIV being a gay disease, which I want to say this again and again and again. HIV doesn't have the first letter of HIV is not LGBTQIA, it's H, and that stands for human. And as long as you're a human, like all of us on here, HIV does not discriminate. So those are, have to, you know, educate, correct, and be like, well, mm, yes, no, yes, HIV, is affective of all of us, but no, it's not, never have been a gay disease. That's the fault of the Reagan administration and people turning a blind eye. So really it boils down to that. And then when you do have the stigma, that breeds a lot of when there's smoke, there's fire. So when you have stigma, the fire is the policies and stuff that gets made to where we have to have awareness days as HIV is not a crime awareness day. And again, if people don't see themselves as HIV possible, then they're not going to take PrEP as a consideration as something that they can have in their arsenal. Or if people are talking about PrEP, then they kind of see it as a negative thing because we still live in a sex negative culture. So that's one side of that of what I see in my everyday life.
And I think that you bring a very important perspective,
Mhm.
because we talk about systems, we talk about access in terms of cost, but also stigma is a really important part. And as you're mentioning, there is a stigma with HIV or PrEP in general being only for gay men, which we know that there are differences in terms of demographics, but as you
Mhm.
are explaining well, is that this goes to everyone that is sexually active. So thank you for bringing that perspective on stigma. John, would you like to add?
Yes, as far as the things that I've seen, the things I've come across in testing, in doing education and prevention is a level of stigma, um, but we're also running into where education is starting to fail us in a sense of not being as comprehensive about sexual health as we should be. And I say that looking at our more rural spaces where we're talking about, I can go to a space and do an education on why PrEP is important, PEP is important, DoxyPEP is important, why condoms are important. And I can still be met with, well, if you're abstinent, this wouldn't happen to you in the first place. And it's like, well, yes, sure, that's the number one way, but also you're not taking into account the blood exposure that could happen, that could take place at a workspace. Or, hey, I'm a nurse and I work at a hospital. I might get stuck by a needle. A patient might have open sores, and this may be how I come in contact. So we're not even talking about those instances. We're just talking about the sex piece in general. Um, One thing I've also come across is noticing that as the as administrations come and go, insurance also tends to come and go as well. And I know insurance has become a big part of the conversation, but especially now when we see an uptake or not an uptake, an increase in people not having insurance and not having that access, where can they go to get their PrEP? And then we think about the different side effects of it. And specifically in Black and Brown communities, as we're more so affected by kidney disease and bone marrow diseases as well, that becomes a concern. And so it is the accessibility that becomes an issue, whether it's how can I get to my appointments? Can I actually afford my appointments? Will my insurance cover this medication? And so this a mix of education and accessibility that becomes the big stopping point for a lot of people on PrEP, specifically in, well, not even specifically, but just covering the South in general, from Virginia down. Um, and that is just, again, from my personal experiences and things that I've noticed.
And thank you for that perspective. And I wanted to bring you in, Taimur, as a provider and also as representative of our organization that provides services. How hearing John and Jason in terms of the some of the barriers that we observe as a community, which I'm sure that are not new for you, how would you recommend advocates or other providers to navigate these complex barriers?
Yeah, that's a good question. And I think that's like the $1 million question here, right? So, in terms of like the stigma I mentioned, that's very real. And that's why I feel it's important to talk about sexual health from a pleasure and choice perspective rather than like a risk perspective. I think humans are for the most part, there are asexual folks, but sexual beings. It is how we procreate. It is how we continue. It is how we find connection, intimacy in relationships. So to disregard it is a little naive and ignorant. So I have to take those criticisms with a grain of salt, right? And then I think the other conversation about HIV possible, which I love that, and also talking about the H and the human of it. I think it's important to also make sure we're talking about this not just in MSM or gay, hetero, homosexual relationships, but the higher increase in rates of HIV acquisition has been in Black women or in women in general. So I think we've seen recently pharmaceutical companies put a spotlight on it. I know Mr. did a few events with like Cardi B, and there are a few other people that have actually put a spotlight on women receiving PrEP, which is great. But I think that conversation needs to continue. Like I know from my straight friends, like they have no idea what PrEP is either. And so I think the more people we tell, the more we normalize the conversation around what PrEP is and away from the worst of the AIDS epidemic, which is where a lot of people's brains first go, right? So that's number one. Number two, I think folks here mentioned a lot of really tough things that healthcare centers have to deal with. I mentioned cost briefly, and yeah, I think with administrations changing and the way we see subsidized healthcare insurance, it's problematic, and every state's different. Like that's the thing that is so infuriating about the US. It's not only every state different, every healthcare plan in every state is different. And so like it's not easy to provide blanket cookie cutter direction to centers on how to manage this. And the other thing that I've heard is like, yes, the education system, well, the education around PrEP is it's not great. I'm not impressed, right? And this has been around since 2012, and we're fully aware of the fact that we're behind in a lot of this stuff. How do I navigate it? There are barriers that are embedded within our societies, including healthcare literacy issues, educational inequality, power dynamics that are completely off. And there's a lot of medical distrust from folks that don't regularly get healthcare or good healthcare, right? And that's going to be hard to overcome. So I think with the advent of the internet, mobile phones, there is a real power to providing digitized and also standardized information to patients. So if you go into a doctor visit and the doctor's already overwhelmed by your past medical history, they're getting to know you and they haven't even talked about PrEP yet, right? There should be a method in which healthcare centers through the EHR send out, hey, you would qualify for PrEP if you check one of these off. If please set up, like, click this button to set up an appointment with your provider, either telehealth or in person, to discuss PrEP for you. Empower the patient, like put choice in the patient's hand, right? I think the way I also like to talk about PrEP with patients is I like to talk about empowering patients, right? In the past, there was almost like a contact tracing fear of how we were saying, know your status, tell your partner your status. That is no longer the case, right? Your HIV status is your responsibility, no one else's. It's none of your business what the other person's status is. I'm sorry. Like, that is not how we function in 2026. There's enough stuff out there where if you don't want HIV, you don't get HIV. You figure that out. And so teaching patients what is in their arsenal that they can use to feel more comfortable when they're having sex, which is already so messy, vulnerable, and not fun sometimes, that they don't have to think about that. So centering choice, pleasure, and consent, like that's the thing. In terms of other stuff, it's literally going to be just providing the information, trusting it gets out there. So forums like this, using EHRs, talking to your communities, getting involvement from CABs and other community organizations is like paramount. I feel like I rambled a lot there. I apologize.
No, thank you so much for that. And I wanted to highlight two things that you mentioned. And one was centering sex and pleasure, because that's something that I agree with, that I agree with, in terms that sometimes the messaging around PrEP is so medicalized that you bring in some people, but you also push out some people that don't really resonate, messaging that doesn't necessarily resonate with the actual lives of people. PrEP is to enjoy sex, to have healthier sex lives. So how do we kind of develop messaging that resonates with community, that community understand that is not a doctor's consult, right? That we are just talking in a language that is accessible, thinking about why are we engaging in PrEP, which is safer and enjoyable sex. And the other thing that I wanted to mention is you mentioned about empowering patients. And if I can also add in here that that's one of the things that we have seen as having the most impact, at least from the perspective of the Gay Men of Color Fellowship. Um, and I'm going to share a quick a link on the chat, because in the chat you can see that there's a report that we did in terms of what is stopping the access to PrEP, but also what is supporting people to have access to PrEP. And what we did was that we trained some of the fellows in conducting a focus group, and they were the ones that conducted kind of these conversations with community. That to say that in the process of empowering people or of empowering clients, patients, or advocates is also a way to provide skill set and also to provide tools for them to feel empowered, informed, and also become trusted messengers. Those same messengers that are going to go talk to their peers, that their peers trust, that they talk the same slang, the same accent, the same language. So it just wanted to highlight that, the importance of really bringing in community into these conversations, because community is ultimately who's going to save community, and it's also who's ultimately going to be passed along these messages to others. And before we continue, Taimur, there's a comment in the Q&A box that I see that you are typing your answer, but
I was
if you
typing the
can,
answer, but I can just say it out
yeah,
loud. So the
okay,
question was in my initial pop-up about sex, I referred to safe sex. This person says I'm old school. We used to call it safer sex. Has a standard changed? And I was just responding. I'll just read it out. I was going to say, I might have spoken a little too quickly. I think what I would say is responsible sex or sexual practice. Safety and responsibility, as mentioned in the chat by Andrew, also it kind of falls on the individual. I think I might change the terminology and how I use it depending on the audience and who I'm talking, what I'm conveying. But I think both are fine. I think it depends on who you're speaking to. But yes, I appreciate that.
thank you. And I think it also brings the conversation about defining safe sex, right?
Yeah.
Is it condoms only? Is it PrEP only? Is it both? Or how does it look for each individual, right?
Yeah.
Um, And now again, for the audience, please feel free to add your questions to the Q&A box or to the chat. And I feel lucky that we also have Jason and John as folks that are engaged with Len. So it's important to have the perspective of people that are actually using Lenacapavir. So I wanted to start the conversation about what led you to, despite all the challenges that we have discussed in terms of stigma, lack of education, lack of knowledge, awareness, what was the main motivator for you to take Len? Let's start from there.
Um, so for me was kind of freedom from taking pills every day because I'm not gonna lie, and I read an article about this before. Pill fatigue is very real. Especially if you do have mental health challenges. For me, I struggle with depression and anxiety. So when I'm going through that, pills be the last thing I want to take, especially for that. So, and once I heard about lenacapavir, uh, once I heard about it, and especially it being twice a year, I've intentionally held off of the other injectable on the market just because I don't want to come in to get a shot every 2 months. I don't want to do that. I would want to just get the one the first one, then the second one, just every 2 years. That's more good for me. And then whatever. And there was another, any other different kinds of prep coming down the pipeline. If it's a implant, that's a 2-year implant. I may want to get on that too because I want to be for me, I want to be the first one on it, or one of the few on it because I want to just have that already on me, running through me, whatever the case. I want that I like prep is already, I've been on prep since 2017. Yeah, 2017. And it's already been a game changer in safeguarding my status and putting that into my hands. And again, a lot of things that Taimur said about since I being on prep has empowered me to just really take control of that and getting tested and the whole 9 yards with that. So it's really giving me that autonomy to really care and take those matters into my own hands and having those relations with my PCP or provider and getting tested. And so that's why I wanted to get on Lenacapavir. So I wouldn't have to take pills every day. So now, prior to me getting on Lenacapavir, I'm taking my Descovy and any other sort of medication I'm on. So now I have to get better with still taking my other medications because I usually base taking my other meds around my Descovy. So now that I'm not on pill form, daily pill form, or probably more, it's like I kind of dropped the ball on that a little bit for the other medications, which is still important. But it does give me that confidence that it is, working. I believe in it, and it's been really, really good. Now, for any other stuff, especially about concerning lenacapavir, because it's an injection, um, there will be nods, but for the nodules on my body, especially because I got it on my legs, I feel them a little bit, but they're small. So, and they do get in the way a little bit, but over time it does heal. It does heal. So it does heal a bit. So, but there will be nods. So just be mindful of that. I sit down. If you're already used to giving yourself injections, if any of us take um HRT, self-administering injections and stuff like that. Those are also subcutaneous, and or just familiar with that, kind of similar to that. Then you may know how to, what to expect. But yeah, with Len, yeah, I've intentionally hold off on it on the other ones until getting to Len. So yeah, and I'm excited to be able to put the pills down and pick the shots up. So.
And as someone that is in oral daily prep, I can definitely see how that would change my whole kind of routine of taking other medications together with prep. So I totally get it. But it also talks about kind of for people that have adherence challenges, how this new technology can really support that, which also takes me to it's not that one is necessarily better than the other, but also how we can have as many options as possible to show people, to tell people, okay, these are your options in your prevention toolkit. Which one do you think works better for you? Whether it is, starting from condoms that I don't think we talk about enough, but also about these new technologies and everything that is in the pipeline, like Taimur and you have mentioned about um, uh, implants or pills that are longer acting. And yes, that's really important. I'm really, really excited from the science perspective about seeing these things hit the market. But also, let's not forget that there is technology that is still available and that we haven't been able to necessarily close the gaps in access. So keep thinking about the what is it that we can do, because technology in itself is not going to close those gaps, but the work that we do as advocates, how we engage in policy, and how we really push for these changes from within. So I just wanted to make that comment. John, would you like to share some of your experience, your motivation to engage with Len?
So I am actually still in the process of trying to start on lenacapavir. Um, I'm gonna try to make this story as short as I can. But I do have a partner who is HIV positive. And so me being on PrEP since 2020, I've been able to do what I can to maintain my at my negative status, but also maintain a sex life that both of us are okay with and both of us are appreciative of. And I think it kind of goes back to my experience with GMOC at the last USCHA when we talked about HIV, aging, love, sex, pleasure, and those things. And I look at PrEP and I look at how other people define, oh, well, PrEP is just for the people who want to do what they do out in these streets. And it's like, okay, sure. But they have the option to do so because this is the type of sex that they want to have. This is the type of sex that fits for them. If that doesn't fit for you, then that's fine. You can move on to the other direction, respectfully speaking. But it is in my interest to be on PrEP. Yes, we all love the streets. The streets is fine. There's no problem with being outside, being in the streets. However, it's the type of sex that you have that is okay for you. And that is one of the big things that I try to express to people when talking about PrEP, condoms, dental dams, the whole nine. Again, insurance right now is becoming a bigger issue just for me to be on Lenacapavir just because it's not as affordable. And so still maintaining the scripts that I do have with Descovy is becoming the thing. However, I'm not going to say I suffer, but I maintain and deal with ADHD, depression, anxiety as well. And I've never heard of pill fatigue. So thank you, Jason, for putting me onto that. But I'm an asthmatic. I've been taking medication since I was maybe 4, probably earlier. And to take medication every day is like a norm for me. But as I've gotten older, it's still like, oh my God, again. And then it's that sense of, oh, I forgot to take my PrEP. Crap. Oh my God, I forgot to take my PrEP. And then that continues to pile on. So instead of me forgetting to take it, why not just do an injection that's every 2 months? I'm still going to have to get tested every 3 months. Like, that's fine. Or every 2 or 3 months, just that's fine. That doesn't bother me. But if I don't have to get an injection every 2 months in the cheeks, that's great. That is perfectly great for me. That's fine. If I can do it every 6 months, that's just a little more convenient for me. Plus, I'm busy. So I'm going to forget at least once or twice, oh, I have to take this medication. Oh, no, I already took this. I'll just go get my little injection in August, September, or whatever, and call it a day. And I think that's the thing that people have to clue in on, not just with PrEP, not just the injectable or the pill form of PrEP, but just sex in general. Is this form of sex something that I'm okay with? Or do I need to look at other avenues to define what safe sex or safer sex is for me as an individual? So.
And I wanted to comment on 2 things. One, thank you for clarifying your experience accessing PrEP, because I think it speaks about the complexities of the system, right? The system that we have to navigate to have access into the healthcare, and also just the many barriers that we see in terms of cost and providers kind of knowing what it entails and having to go to specific places. So thank you for that, because that's actually one of the main issues that we have seen, right? Kind of navigate, and it also speaks about how organizations, the structure of the organization that are community led, really understand these barriers, really understand what the community is, and develop structures or strategies from within the organization to address those needs. And the other thing that I wanted to mention is about the variety of options, particularly as adherence becomes a challenge, particularly in times like now, where I feel like there is so many things happening, that there's chaos around us, and thinking about a pill every day is not necessarily accessible for everyone. So just making sure that people know more about this, that when we approach this, we are kind, and that we are understandable of kind of where we are historically, and where our community, which is fighting many things in regarding the economy, regarding the immigration status, regarding the persecution. So how do we kind of remove one thing from their mind so that they can really focus, kind of a little bit, kind of forget about their sexual health, because that's taken care of, and also provide more space for people to focus on other things. And Taimur, I see that you raise
Yeah, I
your
just want to thank you so much, John. Actually, both Jason and John and Damian. Thank you both. Thank you all. I don't know you, John, so I'm not gonna make any assumptions, but there's a couple things that also came up that I want to be clear about. I think when we're talking about medical literacy and the way the healthcare system is educating people about prevention, there are a few things that I want to make sure everyone kind of knows. One is it's not just oral prep and an injectable. There are other modalities of prevention, right? U equals U, zero transmissions, right? So I know you mentioned your partner is living with HIV, and you didn't give us a lot of color in terms of what your sexual practice was, but I want to emphasize that people living with HIV who take their medication in a real world setting cannot give HIV to their partner. Now, have I had patients come in to my office, assert a discordant couple, and say one is HIV negative, one is HIV positive, and they're asking about PrEP? I have to say, you won't get HIV from your partner. But as I mentioned around sex being pleasurable and you feeling comfortable in your skin, whatever you need to feel comfortable, as long as it is safe for me to prescribe, I will prescribe it. Right? It doesn't necessarily mean that you need it. The indication isn't there. But if it is something that'll help you build intimacy with your partner, great. And again, I also don't subscribe to there being heteronormative relationship structures. So I understand like the streets be streeting, right? So like I also don't want to make any assumptions about what people are doing outside of their relationship. But you brought up the relationship, that I felt it was important to mention that. And the other thing I'll say is, and Gilead's going to kill me, which is like Descovy is not the only oral drug out there, right? It is the one that providers who are inexperienced with PrEP will reach for because they were told it was newer and that there's a copay coupon, and so your patients will benefit from it. Truth of the matter is you can use on-demand PrEP from the generic PrEP medication as you see fit. It is a little complicated. There is a little bit of education involved there, and that is equally effective to Descovy, right? I mean, there's a couple caveats, but they're so specific. I find myself switching people into generic form more often than not, just because why not? It's cheaper, there's more data, all that fun stuff. So just wanted to name that when we're talking about PrEP, we're not just talking about injectables and oral daily Descovy. There are like other options, U equals U, on-demand PrEP and other stuff. So, but that requires education, right? Like that requires lived experience and trust with those regimens. But that's it. Those are my 2 cents.
Yeah, and thank you for bringing the perspective on U equals U. I feel like sometimes we talk about prevention, we only talk about going back to kind of medicalizing and just pills and injectable, but it's also other side related to treatment that it's also about, that also talks about prevention. So we are at time, and I wanted to thank you all for taking your time to join us today, and thank you, Jason, John, and Taimur, for your incredible insights. It's always a pleasure working with you, and I cannot wait to continue collaborating with you in the future. Thank you all so much.
Thanks all. Appreciate it.
Thank you so
Thank
much.
you.
Bye, folks.
Bye.